on 17th of April. World Federation of Hemophilia has chosen 17th April for Hemophilia Day because their founder Frank Schnabel was born on this day. He founded WFH in 1963, and now 147 countries and WHO have given recognition to World Federation of Hemophilia. The theme of the event of this year is Access for All, Partnership, Policy, Progress, Engaging with the Government, Integrating Inherited Bleeding Disorders into National Policy. So as you know, hemophilia is the most inherited genetic disorder that impairs the body ability to make blood clots, a process that is needed for stopping the bleeding. This results in people bleeding for a longer time after an injury, easy bruising, and increased risk of bleeding inside joints and inside the brain. There are two main types of hemophilia. Hemophilia A, which occurs because of low amounts of clotting factor 8, and hemophilia B, which occurs due to low levels of clotting factor 9. Other types include hemophilia C, which occurs due to low levels of factor 9, and parahemophilia, which occurs due to low levels of factor 5. Diagnosis is done by testing the blood for its ability to clot and its level of clotting factors. Missing blood clotting factors are replaced to treat hemophilia. This may be done on a regular basis, or this may be done at regular intervals, or during the bleeding episodes. Replacement may take place at home or at facility level. The clotting factors are made from human blood, or they can be made from recombinant methods. It is seen that up to 20% of the people develop some kind of antibodies to the clotting factors, which makes treatment more difficult. By raising awareness and bringing hemophilia and other inherited bleeding disorders to the attention of the public, we can increase sustainable and equitable access to healthcare and treatment. So creating awareness about this life-threatening disease is very, very important to reduce the number of deaths caused by this disease. With respect to Haryana, if we talk about Haryana, then I can say that in Haryana there are 700 patients there that are living with hemophilia. Out of these 700, 598 patients are living with hemophilia A, and 85 patients are living with hemophilia B. 17 patients we have identified, they have developed some kind of antibodies that we call inhibitors after long usage of factor 8. There were some hospitals such as Ambala, Karnal, Rohtak, Hisar, Bhiwani, and Gurgaon. They were designated as primary healthcare treatment centers for hemophilia because of the availability of all medical and paramedical staff. However, we have revised this policy, and now anti-hemophilia factor is given in all the district hospitals. Further, Haryana government has already decided to provide free transport facility to all the hemophilia patients. Along with that, one attendant is also allowed to have free transport facility. Haryana government is also providing free education up to 12th to all the hemophilia patients. Photo ID cards for hemophilia patients have been given. Diagnostic facilities for coagulation factor 8 and 9 is available in our PGIMS Rohtak. Blood units are provided free of cost to all the hemophilia patients. Another great decision that government has already taken is that if the patient of hemophilia is admitted in any hospital anywhere in the country, and because of any emergency he needs AHFs, then reimbursement up to 80,000 will be done after production of the bills. So greater involvement of community is urgently needed to address the problem of identification of patients living with hemophilia. In order to motivate the community, Haryana Government Health Department and NHM has started providing funds on the World Hemophilia Day to all the districts to increase the awareness. There is a constant endeavor to help the patient to live close to normal life. For ICHH, Integrated Center for Hemoglobinopathies and Hemophilia, are successfully running in district Faridabad, Hisar, PGMS Rohtak and Balakand. Now we are going to start in 4 new centers in district Gurugram, Yamunanagar, Bhiwani and Sirsa. So, and moreover, to facilitate these patients, government has also started procuring factor 7 and FIBA from our procurement arm HMSCL for patients living with inhibitors and not responding to regular treatment. I would stress upon the need for partnership and collaborations to achieve greater milestones in this direction. NGOs and public platforms can be used to create more insight into this disease. This is the disorder which is causing major havoc in our region. Around one patient from 10,000 to 30,000 males have been identified. On the occasion of World Hemophilia Day, let us all come together and stand in support of those suffering from this blood disease. At the end of my speech, I would like to express my gratitude to the team of Voice of Healthcare who have given me this opportunity to interact with you all. Thank you all. Thank you.
सबसे पहले वॉइस ऑफ हेल्थ केयर को धन्यवाद कि आज आपने वर्ल्ड हीमोफीलिया डे पर मुझे अपनी बात रखने का अवसर दिया है। हीमोफीलिया एक रक्त स्राव से जुड़ी हुई बीमारी है। मैं मेरी बात को सुनने वाले सभी श्रोताओं के लिए अगर मैं बहुत सामान्य तरीके से सहज भाव से कहना चाहूँ तो मैं इसको इस ढंग से बताना चाहूँगा कि जैसे हमारे शरीर पर चोट लगती है, जब सतही चोट है, सामान्य चोट है, बहुत गहरी नहीं है, उस चोट में क्या होता है कि खून बहता है और थोड़े समय बाद नैसर्गिक तौर पर, प्राकृतिक तौर पे शरीर स्वतः ही उस बहने वाले खून वाली जगह पे रक्त का थक्का बनता है, खून का बहना रुक जाता है। तो ये जो ब्लड क्लॉटिंग है यह स्वाभाविक तौर पे होती है, पर जिनके अंदर इस ब्लड क्लॉटिंग को करने वाले, ब्लड क्लॉटिंग के लिए जो उत्तरदायी फैक्टर्स हैं जो वो नहीं होते हैं या अपेक्षाकृत काफ़ी कम होते हैं, तो ऐसे जो व्यक्ति हैं वो हीमोफीलिया के रोगी कहलाते हैं। यह बीमारी जो है यह दुर्लभ बीमारी है और यह आनुवंशिक जेनेटिकली डिसऑर्डर के कारण होती है। यह माता पिता से बच्चों तक पहुंचती है और कई बार यह बिना किसी फैमिली हिस्ट्री के अंदर, बिना किसी पूर्व दृष्टांत के भी यह बीमारी हो सकती है। हीमोफीलिया के अंदर जो इसके लिए उत्तरदायी जो जीन है वो एक्स क्रोमोसोम से संबद्ध हैं। जैसा कि हम जानते हैं कि जो फीमेल चाइल्ड है इसको एक्स क्रोमोसोम माँ से, एक्स क्रोमोसोम पिता से मिलता है, और जो मेल चाइल्ड है इसका एक्स क्रोमोसोम माँ से और वाई क्रोमोसोम पिता से प्राप्त होता है। चूंकि यह जो उत्तरदायी जीन है वो एक्स क्रोमोसोम से संबद्ध है, तो सामान्य वैज्ञानिकी के सिद्धांत के आधार पर हम ये समझ सकते हैं कि जो माताएं हैं वो इसके लिए कैरियर हैं, और ऐसी माताओं के जो मेल चाइल्ड हैं, एक्स वाई में एक्स अगर इस हीमोफीलिया के लिए उत्तरदायी जीन से संबंध वाला है, ऐसा एक्स अगर उसमें है, तो एक्स वाई वाला जो मेल चाइल्ड है वो इसका रोगी होगा। हीमोफीलिया रोग को अगर हम फैक्टर के आधार पर बांटें तो हीमोफीलिया ए, जो ज़्यादातर जो पेशेंट्स में हीमोफीलिया ए ही होता है, हीमोफीलिया ए इसके अंदर फैक्टर 8 का अभाव होता है। हीमोफीलिया बी जिसको क्रिसमस रोग कहते हैं, जिनका नंबर अपेक्षाकृत काफ़ी कम होता है, इसमें फैक्टर 9 का अभाव होता है। और ये जो ब्लड क्लॉटिंग से जुड़े हुए जो फैक्टर्स हैं, इनकी जो शरीर में उपलब्धता है उसके आधार पर इन हल्का, मध्यम और गंभीर रोगी, इन श्रेणियों में इसको वर्गीकृत किया गया है। अगर 5 से 40% तक यह फैक्टर सब उपलब्ध हैं तो ये हल्का रोग है। अगर 1 से 5% तक उपलब्ध हैं तो ये मध्यम श्रेणी का रोग है, और 1% से कम है तो ये गंभीर रोग है। हीमोफीलिया के संदर्भ में अगर मैं राजस्थान की बात करूं तो राजस्थान में अनुमानतः जो इसके रोगी हैं वो लगभग 1000 हैं। यहाँ अच्छी चीज़ ये है कि जो मुख्यमंत्री निःशुल्क दवा योजना है उसमें राज्य के सभी हीमोफीलिया मरीजों को निःशुल्क ये जो फैक्टर हैं ये उपलब्ध कराए जाते हैं। एक चीज़ और अच्छी है कि देश में सबसे पहले मरीजों को जो फ्री रिकॉम्बिनेंट है वो भी एनएचएम और गवर्नमेंट ऑफ राजस्थान के सहयोग से उपलब्ध कराए गए थे। इसमें राजस्थान में 6 स्पेशल डे केयर सेंटर भी चलाए जा रहे हैं। हम जानते हैं कि 40% से अधिक दिव्यांगता होने पर दिव्यांग प्रमाण पत्र मिलता है और हीमोफीलिया भी जो दिव्यांगता की श्रेणियां हैं उनके अंदर शामिल है। तो चिकित्सकीय बोर्ड की जांच के पश्चात 40% से अधिक इनकी दिव्यांगता जो है वो इन फैक्टर्स की उपलब्धता के आधार पर तय होती है, तो उनको ये प्रमाण पत्र दिए जाते हैं। राजस्थान के अंदर माननीय मुख्यमंत्री, माननीय चिकित्सा मंत्री और हमारे आदरणीय शासन सचिव के निर्देशानुसार फरवरी और मार्च के महीने में हीमोफीलिया और इनके साथ साथ थैलीसीमिया और सिकल सेल एनीमिया के जो रोगी हैं उनके लिए मेरा प्रमाण पत्र मेरा सम्मान एक कैंपेन चलाया गया था ताकि इनमें जो पात्र लोग हैं उनके दिव्यांग प्रमाण पत्र बन सकें। यहाँ यह भी मैं बताना जरूरी समझूंगा कि दुर्लभ बीमारियों के लिए राष्ट्रीय नीति 2021 बनी है, जिसका जो उद्देश्य है वो एक एकीकृत और व्यापक इसका जो निवारक रणनीति है उसके अंतर्गत काम करना है। इसमें जैसे शादी से पूर्व काउंसलिंग है, गर्भधारण के पूर्व स्क्रीनिंग और काउंसलिंग, गर्भधारण के पश्चात बच्चे के जन्म के बाद अगर लक्षणों के आधार पर रोग का पता लगाना है। इसमें दरअसल जो परामर्श है वो बहुत ही महत्वपूर्ण एक बिंदु है, तो इसके लिए परामर्श केंद्र लगातार चलता रहे। राजस्थान के अंदर हम शीफू के माध्यम से और चिकित्सा विभाग के माध्यम से जो पीडियाट्रिक्स हैं, मेडिसिन विशेषज्ञ हैं, इनको एसएमएस हॉस्पिटल के माध्यम से इनको स्पेशल ट्रेनिंग भी दिलवाई जा रही है। इस वित्तीय वर्ष के अंदर हमारा विशेष ध्यान हीमोफीलिया से जुड़े हुए जो विभिन्न संस्थाएं हैं जहाँ इनका प्रिवलेंस ज़्यादा है और जहाँ लोग काम करने के इच्छुक हैं उनको लेते हुए हम कुछ TOTs तैयार करेंगे जो इसके बारे में जागरूकता लाएंगे। मैं आप ये वॉइस ऑफ हेल्थ केयर के माध्यम से यह निवेदन सभी से करूंगा कि वर्ल्ड हीमोफीलिया डे पर हम सबका ये संकल्प होना चाहिए कि लक्षणों के आधार पर इस रोग की जो जानकारी है वो अगर मिले तो हमें विभिन्न सरकारी चिकित्सा संस्थानों पर मौजूद ये जो फैक्टर उपलब्ध कराए जा रहे हैं उनका लाभ, परामर्श का लाभ, इसके अलावा जो स्पेशलिस्ट हैं उनसे उनकी जानकारियाँ ये सब हमें लेनी चाहिए और इसके बारे में एक बहुत ही स्वस्थ सकारात्मक माहौल बने, ऐसा मैं सोचता हूँ। मैं इस अवसर पर पुनः वॉइस ऑफ हेल्थ केयर को धन्यवाद दूंगा। मैं तमाम सुनने वाले इस वर्चुअल प्लेटफॉर्म पर वीडियो को देखने वाले हमारे सारे जितने भी श्रोता हैं, साथी हैं, उन सबको नमस्कार कहना चाहूँगा और मैं चाहूँगा कि एक बहुत ही स्वस्थ राज्य, स्वस्थ देश, स्वस्थ दुनिया बने। इसके लिए बहुत ज़रूरी है कि हम ये जेनेटिक डिसऑर्डर की जो बीमारी है इनके बारे में विभिन्न जो परामर्श दिए जाते हैं उनका हम पालन करें। आजकल विवाह पूर्व जो स्क्रीनिंग है यह भी एक बहुत महत्वपूर्ण जिम्मेदारी बनती है और एक नागरिक के तौर पर भी जिम्मेदारी बनती है और विवाह के पश्चात जो बच्चे हैं उनको कोई तकलीफ ना हो, विभिन्न रोगों के संदर्भ में मैं निवेदन कर रहा हूँ, उस पर भी हमारा फर्ज बनता है कि हम जागरूक बने। मैं इसी के साथ मेरी बात को समाप्त करना चाहूँगा। आप सभी का बहुत बहुत आभार, धन्यवाद।
Good morning, everybody. It is my pleasure to be a part of the World Digital Forum on World Hemophilia Day. As you are all aware, hemophilia awareness is very less in the country, in this Karnataka and in the country as a whole. Only on the World Hemophilia Day, all of us get together, and then again, most of the time it is pushed to the background because many other major diseases take the place. And now to last 2 years, it has been the time of COVID and COVID pandemic. So somewhere we have fallen back on the treatment or management of hemophilia. Karnataka is trying to bring back the focus on non-COVID services, including hemophilia, and I think this is a good start for us also on this World Hemophilia Day. As we are all aware, hemophilia is a rare genetic bleeding disorder which slows the clotting process. So people suffering from hemophilia have the problem of prolonged bleeding following trivial injury. In fact, severe cases of hemophilia, there can be spontaneous internal bleeding. The estimated prevalence rate is about 1 in 10,000. So which means that there should be approximately about 1 lakh people who are affected by hemophilia in India. Out of it, 60,000 should be severe. However, we have only 14,000 persons registered as on today. And in Karnataka, we have around 2,500 people registered. So this means many hemophiliac patients are not even getting diagnosed. They may be going into severe diseases or dying also before they reach a hospital. So this is a major cause of concern for all of us. So major thing is the poor awareness, as I already mentioned, but it is also a cause of concern that there is a poor awareness even among the medical fraternity about the diagnosis and the treatment of hemophilia. So statistics indicate that India, together with China, Bangladesh, Indonesia, represent only 10% of the people with hemophilia who have been diagnosed worldwide. But these countries account for less than 2% of the factor concentrate used worldwide for treatment of hemophilia. This is an irony that there is a yawning gap in the hemophilia care between the developed and the developing countries. So which somewhere we need to take care to bridge the gap. The percentage of hemophiliacs diagnosed, the number of treatment centers countrywide, and the per capita use of factor replacement therapy can be construed as a reliable criteria for judging the level of care available. Compared to the USA, which has 76% of its hemophiliacs diagnosed, a network of 136 treatment centers, and a per capita consumption of 3.4 units, India has only 12% diagnosed hemophiliacs, 85 centers, and a per capita consumption of 0.01 units to about 0.3 units per capita. So the biggest issue, again, I would like to flag is the lack of awareness, even among the urban elites and the educated class, and lack of reliable lab facilities, which is a major cause of concern. We have taken steps on the National Health Mission and the 15th Finance Commission to bridge this gap and bring in the diagnostics closer to the people. So hemophilia, as we are aware, are two types of hemophilia, hemophilia A and hemophilia B. Hemophilia A is where the amount of factor 8 is very less or absent, whereas absence or less amount of factor 9 causes hemophilia B. Nearly 80% of hemophilia patients have factor 8 deficiency, that is, they suffer from hemophilia A. Both types of hemophilia, that is hemophilia A and B, are inherited in an X-linked recessive pattern. So it is a genetic disorder. Hemophilia patients are males. Like I already said, nearly all affected by this disease are males. An affected male cannot pass this disease to his son, while all daughters of an affected male will be the carrier. A carrier female transmits this trait to her sons 50% of the time. The daughter of a carrier will be a carrier 50% of the time if the father is not a hemophiliac. Sometimes, even when there are no traces of hemophilia among the ancestors, a person may acquire hemophilia. This is due to a change or variation or mutation of the genes. The primary treatment available as far as hemophilia is concerned is replacement therapy, replacing the missing or deficient clotting factors, factor 8 or factor 9, depending on the type of hemophilia, through regular infusions. Clotting factors can be derived from a number of treatment preparations, including whole blood, fresh frozen plasma, factor concentrate, non-factor treatments, etc. Theoretically, all these treatment preparations could be used to treat hemophilia. However, there are considerable drawbacks to the use of some of these preparations. The best available treatment in present date is an anti-hemophiliac factor called AHF. In the last few years, factor concentrates have been employed extensively to manage hemophilia and to deal effectively with the bleeding episodes. Derived from human plasma, these concentrates may be infused or injected directly into the bloodstream. They are available in both intermediate purity or pure forms. The purer factors are derived using special monoclonal and antibody methods. Even though a complete cure still eludes us, modern medicine has very effective systems in place to manage and effectively treat this genetic disorder. Though gene therapy is a distant possibility, the best program is to care till the cure is possible. After us to come to the Karnataka perspective, just a few broad things. What we have done, we have about 32 integrated treatment centers for hemophilia and hemoglobinopathies in the state. Blood bank officers have been made the nodal officers of all these centers, and we have 2 staff nurses at each of these centers. Recombinant factor 8A is provided for on-demand therapy for all these ICHH. And also plasma derivative 9 and factor A7 are procured and provided to all these centers. We still have a long way to do in Karnataka, of course in India also, but we have made a few action plans for going forward in Karnataka. One is for establishing a state-level forum for hemophilia. Factor 8 inhibitor screening for all the registered patients, providing prophylaxis to all eligible patients for preoperative cases, providing on-demand therapy for all emergency cases and to all emergency surgeries, antenatal screening to all suspected hemophiliac carriers, genetic counseling, providing recombinant factor 8A prophylaxis to all the eligible patients. These are the few of the things we are looking at in the way forward. We would be very happy to connect with the interested NGOs and to take this forward. I congratulate the Voice of Healthcare for organizing this program and giving a forum for everyone to connect across the globe, and also for giving me an opportunity to express my views. Thank you.
Thank you. I'm very pleased to be part of this forum, and I would like to share the initiatives of the state of Madhya Pradesh. In Madhya Pradesh, we take a holistic view of our blood disorders that affect the population here. I think we are one of the few states where there is a state hemoglobinopathy mission. So we deal with our patients affected with hemophilia, thalassemia, as well as sickle cell anemia. MP, as you know, is a very diverse and geographically vast state, and we share our borders with a lot of other states, and that in a way at times, poses unique challenges in, providing equitable healthcare to all our population. coming specifically to hemophilia, it is a very, very sensitive disease, and there are a lot of challenges which the health administration has to encounter. Why I say so is the level of diagnosis is very, very low, and once diagnosed, the treatment is also expensive. What MP has done is MP has focused on both the parts. We have ramped up our diagnostic facilities in all our districts. In all our district hospitals, we have the facility of not just testing the blood disorder, but also the clotting time, so that the kind of medication that needs to be given to the patients is determined. So we have ramped up our diagnostic facility. This is something as late as 2020 June onwards. This has led to identification of new patients, as well as enabling the patients to get the disability certificate to which they were entitled. Earlier, because of lack of sufficient diagnostics, patients who were entitled to disability certificates were somehow deprived of that. So that is something which MP has taken up. Apart from that, when it comes to the treatment part of it, we have developed a hub and spoke sort of a model. In the entire state, we have 8 hub centers where we have set up hemophilia integrated treatment centers, wherein we map our patients from the different districts. The patients are one time supposed to come to the hub center, and once diagnosed, if they belong to, say, some other nearby district, they get their treatment facility there. We have provisioned for all the factors and drugs which are required for transfusion for the treatment of the patients, that we have ensured that we have sufficient supply. We do it through our medical corporation, and the rate contract for all our drugs and treatment protocols are very, very competitive, and it is provided to our patients free of cost. We do this entire activity in close coordination and consultation with the 3 hemophilia societies that are located in our state, namely in Indore, Jabalpur and Bhopal. Through them, we try to, map the patients, contact them, provide them the timely assistance and treatment that is required, and through our spokes. One specific thing that we did during the COVID was, though we were running a hub and spoke sort of a model, we realized that because of a lot of travel restrictions and lockdowns, many patients were getting affected and timely interventions was being affected. So what we did is, during the COVID time, we decentralized the budgetary allotment as well as the procurement facilities, and we ensured that our patients do not have to suffer and they get their timely transfusions and recombinant factors that are required right in the district level, so that because of travel restrictions, they do not have to suffer. So these are some of the initiatives that the state of Madhya Pradesh has taken. In the roadmap forward, what we are planning is, because if you track the trajectory of the patient, you find that not only that they are suffering from this one problem, they also can lead to other complications. For example, if they're taking transfusions for a long time, then there's the complexity of inhibitors, which leads to a lot of deformities. So we are trying to improve the quality of life and weave in the wellness factor in the lives of the hemophilia patients as well, through our health and wellness centers. We are also provisioning for physiotherapy and other sort of facilities which improves their quality of life. On the digital front, what we are planning is, because we already have this hemoglobinopathy mission, and we have a portal for our sickle cell patients. Similarly, we are trying to have the map the digital data onto the same portal, so that within the mission page we have one data set of hemophilia patients, so that all the coordinations that we do with our societies, or that we have to do with the cross-border districts, is done in a digital format, and it makes keeps the digital health records of the patients safe, as well as it becomes a efficient and seamless way of providing services to our patients. So this in a nutshell is what Madhya Pradesh NHM is doing for the hemophilia patients. Thank you.
On the occasion of World Hemophilia Day, I would like to first start with what we are doing in containing the problems created by hemophilia. As we all know, hemophilia is a genetic disorder, and we have to prevent it by identifying the carrier. Basically, females are the carrier, as we all know. At the same time, we need to save patients suffering from hemophilia. I'm glad to inform that state of Himachal is involved in treating the patients of hemophilia by providing the factors in our hospitals, which is, I guess, easily available. And there is a society which regularly follows it up about the availability that is being given. Now, just to ensure that nobody has internal bleeding, we have allowed from this year onwards the prophylaxis kind of factor treatment for the patients. They can take that particular factor every week. That could save them from internal bleeding. That would in fact save their lives also, because if we prevent the bleeding, then definitely the life-threatening issue won't be there. So that we have started. We are committed. We believe in the principle of Sarve Bhavantu Sukhina, Sarve Santu Niramaya. So we want all to be healthy, fit, and free from diseases. That is the philosophy that we follow. Dedicatedly in National Health Mission, there is a program dedicated to hemophilia, and we'll continue to work on prevention as well as saving of lives of patients suffering from hemophilia. We will also start a program to screen the mothers who suffer from, who basically carry the gene causing hemophilia, and probably by counseling and motivating them, we can prevent the disease from spreading further. In the state of Himachal, there are around 100 plus patients right now, and we are providing them the factors free of cost. I'm sure these facilities being used by these patients on regular basis, and the new introduction that we have done for the prevention and prophylaxis treatment would also be availed by all in order to prevent life-threatening issue whenever there is a possibility. So in the end, I show our commitment. I wish that we are able to contain this disease from spreading further and saving the lives who suffer from this disease. Thank you.
On the occasion of the World Hemophilia Day, and as the theme suggests, it is a responsibility casted upon all of us to ensure that we provide equitable treatment as well as access to healthcare for all the people who are suffering from this condition. On this occasion, I would like to share the experience of Kerala and how we have been able to handle this issue, especially when we're looking at a condition which involves a lot of funding, and management of a condition which involves funding. There is always a very innovative and differential approach which we need to take to ensure that we meet the requirements. And in the state of Kerala, we have been managing hemophilia over the past 2 years through a program called Ashadara, wherein we provide comprehensive treatment to those suffering from the blood disorders, not only hemophilia, but also other hemoglobinopathies as well as sickle cell anemia. So how we've been able to make it happen is through a tweak in our policy where we have broadened our the access of healthcare to those suffering from the bleeding disorders as well. And in this process, the National Health Mission from the Ministry of Health and Family Welfare, Government of India, has been also supporting this activity. And over the last 2 years, we have been very successfully delivering a very comprehensive care to all those suffering from the bleeding disorders. In the state of Kerala, we have, before we formulated a policy, we had a multi-stakeholder engagement with all the associations, especially the World Hemophilia Federation, the Hemophilia Federation of India, also the Kerala chapter. We devised mechanisms and also identified the gaps in the existing system which we need to plug to reach out to those suffering from the bleeding disorders. And after having analyzed and also knowing the disease burden in the state, we have created a 4-tier mechanism wherein we try to deliver services very close to the doorsteps of those suffering from this bleeding disorder. For immediate bleeding requirements, for consultancy, for management of bleeding in the first, what we call the golden hour, we have already equipped our taluk hospitals that is very close to the people with the factors and also all the requirements which are needed to manage the patients. And we've also opened up district care daycare centers in all the district hospitals where there are dedicated beds available for transfusion and also for management of these people who are suffering from the disorders. Those who require higher centers of management, we have our regional hemophilia treatment centers in the 3 places in Kerala. And above them, we also have the medical colleges who are also giving treatment to all of those people who are suffering from these disorders. So what we try to achieve here is to ensure that we have a mechanism, a structure put in place to meet the requirements of all of these people suffering from these conditions. And while developing this, we had ensured that we take even the stakeholder participation into consideration, which is very important. And after having identified the gaps, we have been able to put in a very efficient system. And we have also ensured that we have a stakeholder engagement. We keep getting continuous feedback so that we can improve our systems. So earlier, what used to happen was these factors and other assistance was only available from a few centers in the state. But now we have opened it up across the state so that it becomes very easy and accessible to the people. We have also started prophylaxis based on the case need so that the people will have a better quality of life going forward, and they will also be getting the right treatment. And the kind of management which is coming through a technically sound and advisory group has been also been put in place so that we get all the right inputs, and any kind of a change in the management is also guided by this technical expert group. So with all of this in place, we have been able to ensure that we meet the requirements of all our people. And more than 100 healthcare professionals, including doctors, nurses, have all been trained in management. And this is very important activity. Capacity building and training is a very important activity of management of bleeding disorders, which we have been able to do on a continuous basis. And going forward, we want to make it even more accessible. So what we have tried to do is to ensure that the entire database of these people is captured in our hemophilia registry. Similarly, we'll also be having a registry for other bleeding disorders. And we will have the data pertaining to them and also do a regular check and also follow up on all of these people so that they get the best care and also have a very good quality of life moving forward. And once we have this database, what we also intend to do is also see if we can link it up with Aadhaar so that we'll be able to make use of that platform as well. And with this, the intention is to ensure that the people who are suffering from these disorders need not go to only one place for their management, and sometimes they may not be even having the treatment profiles. So once this database comes into place and everybody has a hemophilia card in their hand, and once the registry is in place, we will be able to ensure that they get treatment at any place across the state, so that the entire database is there. People will know, who are treating them will also know what kind of treatment they've been undergoing, and there will be a continuous monitoring of these people as well. So this is the kind of a setup which we have put in place. And here what I think is possible is a similar kind of systems can be put up across the country, and so there will be exchange of knowledge, exchange of information, and we'll also be able to treat the patients at any place across the country, the same way we've been trying to treat portability cases in the Ayushman Bharat scheme, wherein a patient from some other state is also getting treated in another state. So that kind of a portability can also be set up if we have these databases ready and we have a common registry wherein we share information and knowledge. So I think this is all possible provided we all come together and work as a team. And on this day, I would like to reassure all our friends who are suffering from these conditions that we are all here with you, and based on the kind of assistance that you are requiring medically, we are always ready to help, and we'll also be learning from all of you in improving our systems so that we'll be able to do much more than what we have done earlier. And I thank on this day, I've been asked to speak to all of you. I thank the organizers for this opportunity. I'm extremely glad that I could share the experience of Kerala so that all our other friends in other states, if they have similar systems, is very good. A challenge and ensure that these treatment mechanisms are in place to assist all our friends who are unfortunately suffering from these bleeding disorders. It is a very easy thing to manage, provided we all put the systems in place and we build in capacities to manage the entire thing. So I thank each and every one of you for this opportunity, and I hope that moving forward, we will put in a better system in place for management of hemophilia in this country. Thank you.
World Hemophilia Day. Live panel discussion on scope of future advances and progress in hemophilia treatment organized by Voice of Healthcare. So this year's theme is promoting access for all in partnership, policy and progress. Our main focus for this discussion is to initiate the dialogue to raise awareness about this very sensitive topic for public health awareness, for engaging policymakers and influencers to know about policy interventions and partnerships, and to make treatment more accessible to the public at large. Hence, Voice of Healthcare has taken this initiative to raise awareness by organizing this panel discussion with very eminent experts in this field. Please allow me to welcome Dr. K. Madan Gopal, Senior Consultant at NITI Aayog, Government of India. We welcome you, sir. I also welcome Dr. 𝐸𝐨𝐫𝐥𝐝 𝐇𝐞𝐦𝐨𝐩𝐡𝐢𝐥𝐉, HOD of Hematology at 𝐸𝐨𝐵𝐺𝐲 Hospital, Pune, and Vice President of Hemophilia Federation of India. Welcome, sir. I also welcome Dr. Rahul Bhargava, Principal Director of Hematology at Fortis Memorial Research Institute, Gurugram. We welcome you, sir. We also have Dr. Manisha Mandekar with us, who is the Scientist G and Director, ICMR, National Institute of Immunohematology, Mumbai. She will be with us shortly. So, without further ado, let us start with this panel discussion. As we all know, it is on promoting access for hemophilia policy. My first question would be to Dr. 𝐸𝐨𝐵𝐥𝐝. Sir, what are the potential challenges in improving standard of care for management of congenital hemophilia A inhibitor patients? Also, please, for our audience and for me, give us a short brief on hemophilia, what that disease is, and how important that is to raise awareness. Over to you, sir.
So basically, hemophilia is a congenital bleeding disorder. Common is factor VIII deficiency and factor IX deficiency. History has known these things from Queen Victoria, who was a patient of factor IX deficiency carrier, and in the legacy, the family had hemophilia B patients. Basically, the major problem in hemophilia is the crippling bleeds, and it can be life-threatening bleeds. A lot of patients bleed at least 25 to 30 times a year spontaneously. Some of them, the first presentation can be intracranial bleed, and unless picked up to have hemophilia, it is a mortality or a death rate is very high. One of the challenges that we do not have enough adequate facilities to make a diagnosis of hemophilia. Patients really have to travel over 10 to 12 hours to reach the center to get the primary diagnosis of hemophilia. You also mentioned about inhibitor. Inhibitor is a neutralizing antibody which neutralizes the factor VIII even when given from outside. Generally, the incidence of hemophilia inhibitor in hemophilia A is somewhere between 15 to 18%, whereas inhibitors are a bit less common in hemophilia B. And this is called as the inhibitor testing, and very few labs in the country today, not more than 20 labs in the country today are doing regular inhibitor testing, and it will be a great wastage that if you miss an inhibitor and keep pumping in factor VIII, the person's condition will worsen and will not have any benefit of that infused factor. So this is a short overlay of what is hemophilia and what is inhibitor in hemophilia. Thank you.
Thank you, sir, for so nicely explaining it to us in such a simple, nice language. So my next question is to Dr. Rahul Bhargava, sir. So please explain in brief about different types of hemophilias that we see in India. Is there a difference between hemophilia we observe in India and the different kinds we have in different countries? And what are the different diagnosing methods available for India, for hemophilia in India? Over to you, sir.
Thank you for having me on the show. And hello, Dr. 𝐸𝐨𝐵𝐥𝐝 and Dr. Madan Gopal. It was a pleasure to be with Dr. 𝐸𝐨𝐵𝐥𝐝, who has taught us so many things in this country. And he's the champion, real champion of hemophilia care in the country. So to your question, hemophilia, as we know, so whenever you have a cut or you have a trauma, the body has got substance in the plasma which helps to plug those gaps and plug that clotting material. So in these types, you have got two types of, rather three types of hemophilia, hemophilia A, B, and C. And these clotting mechanism, which is called factors within the plasma, which helps you to plug so that you don't bleed to death. These are the ones, and on basis of that, it has been diagnosed as hemophilia A, where the factor 8 is deficient in nature. And when it is factor 9, which is hemophilia B, and a rare, very rare type, if you factor 11, if it's hemophilia C, which is called as, are no longer used in today's world. So these are the two commonest ones which you have to think about, factor 8 and factor 9. And 85 to 90% people are of factor 8, and 5 to 10% people are of factor B or hemophilia B or factor 9 deficient patients. And across the world, this is the pattern across, and this is an X-linked disorder. So one important thing all of has to understand is the females will be the carriers, okay? Who will get affected is the male who gets affected. So in the male, and at the time of, say, circumcision or any time of surgery, you have a bleeding diastasis or a bleeding manifestation or a bleeding history within the family, then we have to be very much cognizant that these disorders exist. And majority of times to places where we go into Hindi heartlands and up north in Uttar Pradesh, Bihar, many people have not heard of a word called hemophilia. Think about just diagnosing it. The simplest tests are a test called APTT and PT, where blood is being taken and seen whether they get clotted, they get clot or not. If they get clotted, that's fine. If they don't get clotted, we know that there's some factors which are deficient. And then you go on to do a more specialized testing in analyzing the factor levels, factor 8 and factor 9 levels. So anything, and body is also very smart. The normal level will be 65 to 70%. Even if you have got more than 20% or even more than 5% of a factor level, you can live normally. The beauty is body has given everything in abundance. So platelet count of 1,50,000 is what we desire. But how much is required to safe living? 20,000, 30,000. So similarly are the factors. So body has given abundance of factors. So diagnostic, detailed history. And in today's time, where the time is what is very less in today's world, history taking is an art. We all have to remember, friends, whosoever is listening, history before we embark on the journey of getting these tests done. And these are no longer expensive tests. APTT, PT test, which is a clotting mechanism to see whether the blood gets clotted or not. Once we know that blood is not getting clotted, you go on, embark on the journey of finding which factor is deficient, factor 8 or factor 9, because that will decide what kind of a replacement therapy, how much type of a replacement therapy is required, and the severity. So once we know that APTT is prolonged and we know the factor 8 is deficient, you need to know how much it is low. Is it less than 1%, 1 to 5%, or more than 5%? Because that is going to decide your severity and your lifelong journey with this disorder, both in terms of prevention, nature, because then you need a genetic counseling and other so and so forth. But the correct diagnosis is the key in knowing what needs to be done in the future. And that is what Dr. Shashikant is saying, that we need more labs, we need more awareness, we need more dialect in the local languages so as to make them aware of these diseases. And friends, you need not know every disease, but you have to understand as the science is growing, so are the number of diseases are getting unraveled, and so are the new names for the new diseases are coming up. So please stay tuned and understand through these forums that these diseases exist and it can affect anybody across the spectrum.
So nicely said, explained, sir. So impactfully you have made your point. Definitely, we completely agree with you that as this is a rare disease, we need more detection centers, we need more diagnosis places. Yeah.
Hello.
And sorry. Yeah. So let's continue. Moving on. So as government of India has recently introduced these rare diseases as well into its health policy system. We hope there are many future advances coming on into this diagnosis and facilitating better access to care for hemophilia. My next question would be to Dr. K. Madan Gopal. In alignment to the theme for this year for access for all, partnership, policy and progress, what all areas do you feel still require our attention in terms of policy perspectives, especially for hemophilia care access to all? So, sir, over to you now.
Thank you.
Sir, do you want me to repeat the question? I can repeat the question.
Yes, just please repeat it because I got a call from my superior, so that's why.
Yes, we understand. So my question to you is in alignment to the theme for this year, which is access for all, partnership, policy and progress, what all areas do you feel still require our attention in terms of policy perspectives, specifically for hemophilia care access to all?
Dr. Sawant, as you remember, because in 2017 National Health Policy, we have already underscored the need for having a policy of management of the rare and orphan diseases. And subsequently, some committees were formed and which has tried to bring out some kind of thing. But as rightly pointed out by Dr. Rahul and Dr. Apte, that means more awareness is required for increasing the access. We require facilities to detect the case of hemophilia and other associated conditions. We require more access. We require more awareness about that. As rightly pointed out that in the state of hinterlands of UP and other places, people may not be aware about that such conditions do exist or not. Nevertheless, for improving the access, efforts are being made how to detect these problems as early as possible. Now, a lot of focus is given in developing the laboratory infrastructure in the public health system. You might be seeing an integrated public health lab which can happen in the that kind of things are being experimented in the health system, not from the medical college. In medical college, everything is available. But for reaching the health system, you see that how the reach of the health system is there. It is up to each and every village is having a worker who will bring the person to a health and wellness center or the erstwhile sub-health center. Now we are trying to see that how we take our laboratory services up to that level. We have to set each and every primary health center, which is above this health and wellness center, it is equipped to have a laboratory so that this at least the basic parameters which can help in identifying the diseases are being identified. We are trying to see that how these facilities are there so that the access to these facilities are being ensured by the common persons. As has been rightly pointed out by Dr. Rahul, saying that in the hinterlands, that is not available. People may not be aware. Take the example of sickle cell, where in some of the states, the sickle cell belt is there. It is you see that now the sickling test is a very simple test, which has now been taken down to the right up to the community health centers. You are having a sickle cell test. Similar kind of laboratories are available which can help in detecting the hemophilia and other associated conditions. So we are making efforts in seeing that how the access is improved, how the people are being made. We are focusing more on the behavioral change communication, but our module needs to be prepared so that the frontline workers or the outreach workers, they have been able to at least make and build a rapport with the community and push on the message that how to detect, how to come forward, get symptom tested. So these are some of the things I think we are making, but rest of the things are being taken care by the policy, but still a lot needs to be done in this direction.
Dr. Madan, just to add on to that, one approach is, of course, the educating the masses and the policy holders and bringing the APTT, PT to the PHC levels and coagulation test, which Dr. Shashikant is already doing, and you are doing a wonderful job. But at the same time, there's a larger burden on us also as physicians to educate our own colleagues about these disorders which exist in the community, which is not so rare. As we keep on talking about rare to rare things, these are not rare things in our community. So I think at a community level, the primary health doctors like pediatricians, physicians, surgeons, they also need to be aware of these disorders that they exist, and the facility has to be back to them so that they can, what they think, they can diagnose, and from their diagnosis, the right treatment can take place. And then the whole cycle of this access to all will get completed, because the doctors itself, if we know, and Dr. Shashikant will speak on after this, in telling us that even the doctors in the rural places are unaware of these diseases that they exist.
Exactly,
I would say
Rahul.
Rahul and Dr. Madan
Sir,
Gopal
sorry,
and
sir.
Rahul, I would say why villages? Even doctors in cities don't know. So often we see patients, they get operated without baseline PT, APTT, and they bleed on table, and then the complete chaos happens. This could very well be avoided if every patient gets a prothrombin time and PTT and a good history taking prior to doing any surgical procedure.
Exactly. That's why I'm saying when we are increasing the network of the laboratories, the BTCT that can be done by any laboratory technician at the primary health center level. We are trying to see that how these people, they have been oriented to do this simple test. Second thing, as you have rightly pointed out, the basic premise is that the doctor should be made aware that they need to take an history. So that's more important.
Yes.
So that if facilities are available, if the doctor is not aware, he won't be advising any test, and he won't be missing that patient.
Dr. Gopal, there is a clear-cut document now that bleeding time, clotting time should not be done as a coagulation worker prior to any surgical procedure. That has to be percolated down to the community, that kindly do a prothrombin time, PTT, and a good history taking, because BTCT is routinely done, but it is very non-sensitive and non-specific test, and it should not be used as a pre-op evaluation for a surgical patient. And that is the major problem. Even majority of the labs in the cities or doctors only ask for BTCT. They don't ask for PT-APTT. Yes, sir.
So Dr. Shashi very well said.
Whether PTT is available or not, that we need to check. If it is available, it will be done.
Dr. Shashi, couple of years back, we wrote a letter to the President Surgical Association of India saying, let's write the obituary of BTCT, and why APTT PT should replace BTCT in 2022 should be the theme, with access to all, to the surgeons and our orthopedics colleagues.
Correct. And the PT-APTT are not very expensive tests.
Exactly.
Any institute which is doing, say, 20 to 25 surgical procedures per day can very well validate and can justify a PT-APTT setup. It's a very simple test. It costs only 500 rupees both put together. And it is going to save a chaos, risk to the life, risk to the body, if proper PT-PTT is done and then the patient is operated.
Absolutely.
It is so amazing to hear all such leading minds discussing about this disease and coming up with innovative solutions for the problems going on in our country, and trying to come up, a problem means to solve them. So this next question is an open question for all of you. Anybody can answer. I have this burning question of seeing this, new generation sequencing and these sort of latest technologies coming in for detection for rare disease and genetic disorders before, in pregnancy, and that way through genetic testing, through next generation sequencing and such, latest examinations. Can we please touch upon such similar advances in hemophilia research that allows us for better diagnosis and treatment? So this is an open question, please, for anybody.
Do you want to start, Rahul, or should I start? Okay, see,
So you can start, please.
New generation sequencing, NGS, DNA testing, it has got one great advantage, that sample can be transported. You cannot transport the sample suppose there is a patient sitting in Gulbarga and they want to send the sample to Pune for PT-APTT, they will have to separate, and factor assay. They will have to separate the plasma and ship it to Pune on a dry ice. It's not an easy procedure. And every time patient is not willing to go to the center to get the things tested. Whereas the NGS, you have to just send a tube of EDTA, have a proper history and proper algorithms. We will not know the severity, but we can gauge the severity from the clinical presentation. If the person is bleeding 25 to 30 times a year, obviously is a severe hemophilia. So if we can transport the sample, and in fact, transporting the sample for NGS is extremely simple and easy rather than transporting the sample for factor assay or transporting the sample for even plain PT-APTT. So it is going to make a great impact. And if we can really do it in bulk, the volume is so high, because today we have only 26,000 hemophilics registered in National Hemophilia Registry. With the population of 1.3 billion, India should at least have 130,000 hemophilics in the country. So there is underdiagnosis. Once we have made a diagnosis by NGS, we know the mutation. We can trace the carrier female or possible carrier females in the family and can counsel them, help them out with the prenatal diagnosis in future pregnancy. So NGS is going to make a huge impact on hemophilia management, any genetic disorder management, sickle cell, thalassemia, we know. It's a very important tool.
Sir, Dr. Bhargava, sir, would you want to add anything on this one?
Absolutely. So I think the new tools are promising moon and they are delivering one as well. So these new tools and new age tools are helping to diagnose people more correctly, more appropriately, more accurately. They're also helping you to do the prenatal diagnosis at the earliest so that you can prevent these child from being born. And as Dr. Shashi has said, that it helps you to know family screening also, and thus leading to the research point of view also, and helping the science to grow from sporadic mutations to mutations which are running in the family to develop the family trees. So I think these new normal in today's world is, as we are moving along, still we are talking about VTCT. Now the time has come and the COVID has helps you to have a genomic surveillance at place, which is the correct way to diagnose these new mutants. And people after COVID are cognizant of genomics and genomic surveillance. So we have to ride onto this wave of knowledge which has been imparted by COVID from very few things which good has happened from the COVID itself, that the healthcare awareness has increased, and so has the genomic surveillance and genomic understanding in the public's mind has increased. I think these instruments and these technologies are well placed because these are now considered as new normal. So we don't have to shy away from ourselves and say these are expensive modalities, these are only need to be in one center in the state. That's all. New normal is genomics, and the way we are moving in every disease, as Dr. Shashi has said, and as Dr. Madan Gopal will talk about, you talk about myeloma, you talk about leukemias, you talk about cancers. Genomics is everywhere, and in next decade, all your things is going to be decided based on your genomic analysis and genomic surveillance. I can go and tell you about this. We were talking about Janam Patri, then we were talking about blood Patri. Now in future, we are going to talk about genomic Patri in the decades to come by. In the next decade, we'll all have a genomic sequencing and know what is going to happen to us. So this part of a DNA is very, very important. And I always say this DNA is a dinosaur. You can take it anywhere, you can preserve it, and you can use it later down the stream to do the research on these modalities. So these are essential. Country needs it. And we need to propagate these new technologies and adoption to policymakers as well as to the general public.
So very well emphasized, sir. Definitely, this is the future progress of hemophilia that we expect. And definitely, I feel that the voice should be heard by concerned authorities so that we have the access to such services as soon as possible. Sir, another question that I and the viewers wanted to really know is, what are the signs and symptoms? How would we know that a female is a carrier female? It is easy to recognize an affected male or an affected female because there is, long bleeding time, and the bleeding doesn't stop, it being the very basic sign. Other than this, I would want any of our panelists to explain me and the audience what are the signs and symptoms of carrier females, affected females, and affected males.
So affected males, there is no problem. Because they are affected patients, they will bleed spontaneously, they will bleed on provocation. But carrier is a different game. More than half the carriers are completely normal. They do not bleed. They have a normal factor 8 level or factor 9 level. So now science divides carriers into two types of carriers: asymptomatic carriers and symptomatic carriers. So nearly 1/3 of the carrier females can have prolonged HEPTD, can have lower levels of factor 8, but the levels will not be very low. They will be in the range of 30 to 35%. So problem is that unless you have a family history, it is very difficult to do the testing, and ultimately you will need the DNA sequencing to pick up the carriers. But it is very crucial. Like, we call it what we have been talking as a phenotype: severe form, moderate form, or a mild form. Very few families in our country, we know their mutation. We just did surveys, hardly 2,000 patients out of 26,000, we have some genotypic data. And that is the way to pick up carriers in the affected target patient family. There is no point doing randomly. You can't do this as a random test, because it is not as common as sickle cell disease or other genetic disorders as compared to with hemophilia. But yes, there is a hemophilia, severe hemophilia A child. Try to trace out possible carriers and do the genetic testing, because routine coagulation tests may be normal in more than 50% of the carriers.
Thank you so much, sir, for explaining it so simply for all of us. So next question is to you again. In your experience with Hemophilia Federation of India and other associations, what are the 5 main areas where patients' policy level interventions are required to make hemophilia care more accessible to all? And how can organizations working in rare diseases help patients to fulfill these requirements? Over to you, sir.
So, it's quite a long topic. I'll try to concise it. Basically, advocacy is needed. We have to educate each other. Even we have to know certain things in hemophilia. I'm not saying that though I'm a hematologist, I know everything about hemophilia. We can't say that. We have to have advocacy. But certain thoughts I have had on these issues for last few years. So one thing I feel, there should be a dedicated hemophilia program, and there should be uniform policies across the country. Today what has happened, the health is an issue with the state. And if you really analyze the data across the states, today 22 states are supporting cause of hemophilia in some way. I'm not saying it is adequate, but yes, there is some support. But again, the policies are different. We can have a similar policies for the state. We can form something under National Health Mission and have a dedicated program. We have a dedicated uniform policies across the board. Second thing, we should have a treatment center, hemophilia treatment center. We split hemophilia treatment center in 2 categories. One is the hemophilia treatment center and other is a hemophilia comprehensive care center. So hemophilia comprehensive care center is like a referral center. Okay, so there can be a HTC, hemophilia treatment center, in each district using the infrastructure of district hospitals, so that things are available. And these things should be available 24/7, because the bleeding in a hemophilia can be a serious emergency. Like, to give an example of big state like Maharashtra, there are 30 districts, but only 9 district hospitals are supported with hemophilia factors or hemophilia care. Patients traveling for 12 to 14 hours with a bleeding situation can be hazardous, dangerous, to the life. So it should be available at district level. That is one thought in my mind. Second thing, to know that we should have the database. How many patients are there in each district? So we need a robust database. Third thing, government hospitals and especially medical colleges have to get involved, geared up in hemophilia services. To give a data that totally there are 392 medical colleges, private and government. Only 39 medical colleges have factor 8 assay facilities or factor 9 assay facilities. And out of these 39, only 8 medical colleges are in position to do inhibitor testing. This has to change because patient care will depend on these things. And it is possible. It is possible that we can know exactly how many registered patients are there in each district. We know in Maharashtra, me and a couple of my colleagues, we have done the split. Karnataka has done that split. Madhya Pradesh has done and Gujarat has done. Third thing is that there should be adequate and regular supply of safe and efficacious factor. Factor is important because there are, say we want to run a program and we start the things and we should not have shortage of factor 6 months down the line. If we want to run a prophylactic program, it is important that adequate amount of factor is supplied on a regular basis. And this becomes a major issue. Other issue is that today what is happening, like last year, approximately 400 million units of factor 8 was used across the 22 states. But these states, these factor was put in as an individual tender by each state. If we put a common national tender for 400 million units, our tendering power increases, our negotiating power increases, and we should have a regular standardized protocol for tendering this system, and these norms are available. These products have to have a proven safety and efficacy, and there are international norms or there are World Federation of Hemophilia guidelines how to select the product, how to analyze the product, how to assess the product, and then the cost comes down. The cost is the last parameter when the assessment of these products have been done. Most important thing now, people we know today, that prophylaxis is very important and home therapy is very important. Like hemophilia is like diabetes. When the sugars go high and you are treating a complication of diabetes. Whereas you don't allow sugars to go high is the treatment of diabetes. Similarly, now the concept is very clear that when a patient bleeds and you use episodic or on-demand therapy, it becomes a treatment of bleed and not a treatment of hemophilia. Treatment of hemophilia is going to be a prevention of bleed. If you can achieve less than 3 bleeds a year in a severe hemophilia, spontaneous bleeds I'm talking of, you are doing a very good prophylaxis. And prophylaxis is the key. And to do a significant and effective prophylaxis, we have to have a home therapy program. There are 2 states which have started at some level prophylaxis and home therapy. Let me honestly tell you, things are definitely changing. Things are definitely changing for better. Government is really putting good efforts, but we have to have a uniform system and uniformity in this. There is a need to have the directory of the hemophilia treatment centers. And we are taking efforts through our medical community to have a database which is easily available to the hemophilia patients as well as physicians. Suppose a physician suspects or knows he has a hemophilic child or a hemophilic patient and he should have where to send, which is the nearest center. And to do all these things, we have to have a good analysis of the data. We have to have a robust analysis. We have to have an outcome analysis. Tomorrow, if Dr. Gopal asked me, Dr. Apte, we gave 100 million units of factor last year. How many patients benefited? How many patients received dose? How many patients bled through this period? And once this thing kind of a data collection is done, we can formulate our policies for the better in future.
Thank you so much, sir, for so explicitly explaining everything. That was some wealth of golden wealth of wisdom that I could hear from you. And all the points that you pointed out were so appropriate to the things that we require today in our country. And as you rightly said, we have the treatments in place, we have the things in place. We just need them to be more organized so that our efficiency in treating and caring for hemophilia patients increases tenfold. So my next question is to Dr. Rahul Bhargava, sir. Sir, please explain about the replacement therapy, the challenges and efficacy of replacement therapy for hemophilia in our country.
So as we know that there's something lacking which is leading to hemophilia, which is leading to bleeding. And what is that? Factor 8. So mankind, by knowing the pathophysiology, by knowing what was wrong, once you know what is wrong, you can find a solution. And that's what the science did it for us. They find out the replacement for factor 8. Right from the porcine to completely humanized factors, from short-acting to long-acting ones, they are able to find out, and that's what you do the replacement therapy. First, it was on-demand therapy, where people were bleeding, and you gave the factors on demand. When there was a bleeding, you want to replace. And Dr. Shashikant and CMC Vellore has been very active in creating the guidelines for the resource crunch countries like India. What is the minimum factor level which are required to stop bleeding? So you have a CNS bleed, you require 100% factor. You have a joint bleed, 40% factors will be sufficient. For a major surgeries, 100%. For a dental, probably not. You don't require anything, or 5% maintenance is required. So replacement was by the factors, which was of various generations, first generation, second generation, and third generation, which was based on where the source was, from porcine to the completely humanized versions, where there was no animal involved into that. And the cell lines started producing, the cell lines bigger, so that the production can be increased at a much faster pace. And now with these new pegylated forms of factor 8, which has come, which is a long-acting ones, which can be given once in 2 weeks, has shown us that these technologies are helping us to deliver these replacement therapies. So from an on-demand therapy, people realize that if I can make the factor level at 5% or even 3% in a very severe hemophilic, which is less than 1%, the quality of life improves by reducing the bleeding. The quality of life becomes better. And how do that happen? Just increasing by factor level by 2 to 3%. That's all. And that's where the prophylactic strategy for factor replacement came by. So from an on-demand, from SOS basis, you were bleeding. Because you were not able to prevent the bleeding, you were giving factors. So the joints were getting deformed, deformities were setting in, the quality of life was not better. It invented to a prophylactic mode where every second day or a third day, you could give factors without enhancing the immune mechanism to form inhibitors into these patients. Thus the prophylactic therapy came by, and this prophylactic therapy has really changed the life, because all hemophilics want is the quality of life. Once the joint becomes a target joint, they say start bleeding into that, then it is difficult to salvage that joint. The most important thing in replacement therapy is the prevention of bleeding, and thus creating a good quality of life, and that is what is required. So this is in a nutshell, from on-demand therapy to prophylactic therapy, from new generation factor replacements, along with the pegylated form of factor 8.
Thank you so much, sir. That was so nicely explained. So my next question again to you, but as you are a little occupied, I'll go on to Dr. K. Madan Gopal. So, sir, my next question to you is, what are the possible partnerships that can be fostered, that we can foster with the aim of improving hemophilia care facilities in states, and what all resources can we, foster to combat this life-threatening disease? Over to you, sir.
I think the answer lies in the discussions which we are having till now. So, what are the important things which we can just list it out? One is raising awareness. For this, we have to partner with the community level organizations, right up to the corporate level organization. That means we have to tap in the community level resources and the CSR resources for raising awareness. Second thing is availability of the fractions, because we have to promote the prophylactic treatment. For raising for prophylactic treatment, a lot of capacities are to be built in, right from the medical college level to the person who is direct in contact with the direct person, that means to the ASHA level. So a lot of work is to be done. It is not a single mass job, or even public institutions can be doing it. It has to be in partner with the private sector and the NGO sector for handling the capacity issues for identifying, providing prophylactic treatment, making the treatment accessible and available to all these people. Then the other fourth thing which is coming, which is striking, because I was handling with the NACO people regarding the blood banks. Because in most of the blood banks, it's a whole blood transfusion. We have to see that how this blood banks, they are modernized to do the component separations, so that we can have available components and other things available. That modernization is also going on, but still the distribution of these blood banks and the availability is skewed. There are many districts which doesn't have a single blood bank, not to talk about the treating center. Second thing is, even the blood transfusion and the use of the blood, the demand as well as the demand for clinical use, as well as the demand and supply, there's a mismatch. So there's a serious concern there. That means when we are partnering with the different actors, right from the NGOs to the corporate sector and the state governments, we have to see that how to build in capacities, how to raise awareness, how to rope in more resources. Because in public health, if a disease which is having a lesser footprint, that doesn't get prioritized, but though it is life-threatening. But most of the in the resource constraint things, we have to see that in the optimal resources, how best outcomes and outputs are achieved. For designing a policy, we usually see that if you put resources, what would be the effective outcome and output regarding that thing. That's why we call this disease as orphan disease, because nobody looks after that. Another important thing which has been highlighted is creating data registries. Here requires a partnership. We don't have exact data, 27,000 registered people, but the magnitude would be quite high. We see that how we register all these people. We do have a network in the public system, but main bottleneck is the capacities to identify and the awareness among the public to come and access the services available. If they are available, then only they can come into the system and then get registered. If they are registered, then a plethora of services can be extended to them. Our reach is increasing, the footfalls in the public and the private sector is more or less equal. Though the expenses happens more in the private sector, but the footfalls in the public and the private sector more or less the same. So that means access to the public system is right up to a 5,000 population level. That access is there. Now, how to capitalize on this? We have to build capacities, we have to raise awareness, we have to bring people to the system so that we get data and that data can be used and analyzed. Until we are able to influence the policy maker with the data, that is, so many people are there, so much money is being spent for treating this thing. So it would be very difficult to influence all these things, because the other disease and other things, they get prioritized. So that's why partnership is very important to address all these issues. I stop here.
Dr. Apte sir, would you like to add anything to this?
No, as Dr. Madan Gopal sir said, it is very important to have a partnership. It's a teamwork. It cannot happen at a singular level. But yes, we have great opportunities. If we really organize ourselves, I'm sure we can come out with the different protocols and tell the world, this also works. And as I said in my previous discussion also, data is very crucial. We have to nurture that culture to collect data. That is missing, and we have to do that.
Very rightly pointed out, sir. Nurturing the culture to collect data definitely makes sense, definitely. So my next question is an open sort of question. And I direct it to Dr. Rahul Bhargava, sir, now that he's here with us. So in a country such as ours, wherein we have such a large population, affordability and providing affordable care for any disease is a challenge, definitely. So can you please share with the advances that we are making in innovation and research as at institutes, Indian institutes, research institutes, how can we make care more affordable through such innovations? And if you have any thoughts on this one.
So I think the most affordable thing in the country like India with 1.4 billion people and 1.9% of the GDP being spent on healthcare, the easiest way is to have prevention strategy. There is nothing on it, not even US can afford to treat these kind of big populations with factor replacement lifelong. These are chronic illnesses. You have to understand the burden is huge. If you have to have the health economic data, the health burden and the economic burden on the exchequer because of all these chronic illnesses is going to be huge, because we are going to survive longer and longer. When we got freedom, we were dying at the age of 40 years, and now we are going to survive till 80 years. So understanding that fact that these chronic illnesses can be prevented, we have to put our money into prevention and public health by making people educated about such disorders. So in the rural hinterland, still the Janam-Patri is a major thing which we keep on talking about, but you will be surprised not even one network portal on like shadi.com and other things ever talk about genetic counseling onto their websites. So the idea is that we need to make people aware. Second most important thing, the cost of the factors needs to be brought down by innovative technologies and biotechnology advancements, by building up bigger reactors so as to have a cell lines which can lead to mass production at such a low cost, because the country's need is to be fulfilled along with that. And we have seen during the COVID times that when India can manufacture such a huge amount of vaccines at such a short notice, why not factors and factor 8 which are responsible, and that too good quality ones at a lower cost, so that the exchequer loss has been reduced. Still the cost of factor is 11 rupees per unit, which is still very high. And if you have to go on to a private, and thanks to Government of India, which has been able to make available at every district hospital in the country for hemophilics to avail these free factors, it's a huge daunting task which they have been able to fulfill. Third most important thing, the pilferage and the usage has to be checked in. Data technology has to be used in, and the AI has to be put in, so that the usage, the misusage down substantially. Because with the data-driven thing, you know how much the factors are needed, and along with that, inhibitor screening, so that you don't keep on putting the factors into the body without having any utility, and adopting the new technologies like pegylated forms, which has to be brought in along with the what is required as a prophylactic way of treating the patient, so that the quality of life along with the morbidity and the amount of money which is being spent on these patients to get their joint replacement done can be substantially brought down. So I think it needs to be a holistic way of looking at hemophilia, and the newer directions through the innovative strategies needs to be brought in. Data utilization has to be brought in. The AI has to be brought in, so as to reduce the cost of these factors, and thus helping these patients to live longer and with quality of life, rather than having a disability at their hands.
Definitely, sir. So nicely explained. And I see all the points that you have shared, definitely, coming forward more in future. And with our PM's new policy on, digital health mission, making India more Atmanirbhar, we can definitely see AI and all such latest technologies getting integrated with policies on rare diseases, so as to make it more accessible, more affordable, and more effective in general. So it was amazing to have all such eminent people on our platform today, discussing and brainstorming about hemophilia and making it more, making the access possible, and promoting partnerships, policy progress, and efficiency. So I would like to thank all our eminent guests for taking out their valuable time for being with us today. Thank you, everybody. I would also like to thank all our viewers for staying with us till the very end. I hope good amount of information was imparted to you, and now you are a little more aware about rare disease hemophilia than you were when you joined us. Moving forward, I would just like to sign off now by stay happy, stay healthy, stay safe, take care. Thank you so much.
Thank you. Thank you, Dr. Gopal. Thank you, Dr. Asavari.
Thank you, sir. Thank you, everybody.
Thank you. Thank you very much.
Bye, Rahul.
We also have Dr. Shubhra Phadke with us. She is the professor and head of Department of Medical Genetics at 𝐸𝐴𝐺𝐵𝐺𝐼MS Lucknow. Welcome, ma'am.
Hello, namaste. Good morning.
We also have very eminent Dr. Tulika Seth with us, who is the professor of hematology at the All India Institute of Medical Sciences, New Delhi. Welcome, ma'am.
Thank you.
So my question for Dr. Shubhra would be, India has witnessed a major paradigm shift in the treatment of rare diseases and its management over the past few decades. Advances in molecular medicine in this century have markedly improved hemophilia treatment. However, management is still largely inadequate in developing countries. Do you think that practices like carrier detection and prenatal diagnosis can play a key role in the disease prevention and management, ma'am? Over to you.
Yes, I have seen over last more than 3 decades the changes in the management of hemophilia, which are there worldwide and also available to patients in India. There was a time when the anti-hemophilic factors were so costly that hardly anybody could afford, and we had to mainly have a management based on blood products. And that was just life-saving type of treatments, and that too at the risk for the doctor as well as the patient. However, with the government support for the factors and so many things, or especially in Uttar Pradesh, long time ago, the government support started for the management of hemophilia. And that has changed lives of many patients. And of course, as you said rightly, that it is far from optimum treatment. And what we used to sing or say, or Hemophilia Federation used to say that for developing countries or resource poor countries. But I think that time has come now that there is I don't think we can consider ourselves that poor. And hence, I think over next few years, we expect that the state-of-art treatment which is available to developed countries will be available to us. And hence, when we think of carrier detection and prenatal diagnosis, it is basically for those disorders which have no treatment or very poor outcome, or the treatments are very costly. Under that category, hemophilia was a disorder for which carrier detection and prenatal diagnosis was being offered, and we were doing it for the patients. But even at the when the treatment was suboptimal, I will let you know that as compared to the disorders for like thalassemia, or where the lethality, like the child will die if untreated almost 100%, and also disorders like mental retardation or intellectual disability, neurodegenerative disorders, there the uptake for carrier detection and prenatal diagnosis was much great than as compared to hemophilia, because even with suboptimal treatment, many hemophilia patients do lead a reasonably good life. So, of course, we were offering carrier detection and prenatal diagnosis, but prevention by method of prenatal diagnosis involves termination of pregnancy, which though is legally right, still it can never be considered an option or cannot never be considered ethically right. So in this situation, now if you have a family with a child, say 5-year-old, getting good treatment with factors, even prophylactic therapy, and they haven't seen any life-threatening bleeding episode, then now we have occasional cases. But really, the families where the family felt that did not want to go for prenatal diagnosis or termination of the pregnancy if the fetus is affected. So there is this change is going to happen, and with available treatment, and I think that this change is good, because even if for doing prenatal diagnosis for decades, every time we say that fetus is affected and birth of such child can be prevented by termination of pregnancy, it's really very sad thing. In my heart also the family goes through. So I hope that we would not need carrier detection and prenatal diagnosis for hemophilia in next few coming years.
Thank you so much, ma'am, for so nicely explaining it to us. I just had this query while you were explaining this. Ma'am, are there any protocol for for specifications wherein it is specifically laid out if the child is detected to be a hemophiliac before having birth? So, is it legally allowed to terminate the pregnancy? If so, how are the protocols in India, and do they vary with countries from the West?
Uh, yes, this is a very important question. And here I would like first to stress that an option of prenatal diagnosis or termination of pregnancy if the fetus is affected for any disorder, say hemophilia, or as simple as cleft lip, or even serious disorder like Down syndrome or mental retardation. These decisions are personal decisions and not medical decisions. They are based on the medical facts or medical investigations. And hence, when we always say that genetic counseling has to be non-directive, and we can help the family to know what is the outcome of that particular disorder, what are the treatments, and what is the likelihood of that particular treatment to lead to good outcome, and the family can take the decision. Of course, there is legal these things that the medical termination of pregnancy can be done before 20 weeks. Now they have extended to 24 weeks for disorders like hemophilia, where we usually have planned everything. Then the earliest prenatal diagnosis can be done at 12 to 13 weeks. And if there is if you have to do, then termination should be as early as possible, so that it's not physically as well as mentally traumatic for the mother. So from that angle, I cannot say there any protocol, but most important baseline is that the family has to decide whether they will like to go ahead with prenatal diagnosis or termination of pregnancy. In fact, we had a mother who was a carrier, and she had some bleeding episodes, which confirmed that she also is a manifesting carrier. And then, because she knew that she is a carrier, she said she will opt for prenatal diagnosis, but will not terminate if the fetus is affected. She only wanted that information, so that after birth, immediately if the child has some problem, then that those can be very well managed without any serious complications.
Thank you so much, ma'am. Definitely, information is the first step towards cure. And if the patients are aware about this disease and how to manage it and have services at their disposal at good, at affordable and conveniently, they definitely will be able to live with this disease for long, long years. So my next question is to Dr. Tulika, ma'am. Ma'am,
Asawari,
unlike,
just a second.
yeah,
Can I add just one more thing?
yes,
That
ma'am, please.
what I said, that some families may not opt for prenatal diagnosis, but genetic counseling has to be a part of management of every patient with bleeding disorder. So as soon as the diagnosis is made, the family has to be provided this information about possibility of recurrence and prevention. And of course, then they can take their time to decide what is good for their family.
Very rightly said, ma'am. So genetic counseling and getting these counselings done for anybody who is suspected to have such diseases is a must, and awareness should be created around these so that people know that such services are available and they should go for them. So my next question is to Dr. Tulika Seth, ma'am. Ma'am, unlike infectious and non-communicable diseases like CVDs and hypertensive disorders, genetic diseases are given a low priority in India in general. Complex diagnostic processes, lack of awareness among the general population, and huge costs that are involved in disease management can be few challenges that make the approach of these rare diseases difficult from public health standpoint. So, Dr. Seth, since you have been actively involved in the control of hemoglobinopathies, what steps can be taken according to you to fulfill these gaps and make the population more aware about the disease and its management? Over to you, ma'am.
So thank you so much for that question. Hemophilia, as you know, is a bleeding disorder that causes bleeding into the joints and muscles and even into the brain. And it's caused by a genetic mutation which results in a deficiency of clotting factor 8 or clotting factor 9. In about 60 to 70% of patients, we find a clear inheritance pattern with many other male members affected in the same family. Without treatment, these patients can bleed anywhere, and each bleed will last for many days or weeks before it gets better and can result in severe and even permanent disability. And if the bleeding is in a danger site like in the brain or neck, it can even lead to death without treatment. Many patients, when they don't have access to treatment, can have up to 2 to 3 bleeds in a month, which would mean, they can have 20, 30, 40 bleeds in a year. In 60 to 70% patients, we know the mutation, and so it becomes a little bit easier to do genetic counseling, and they are more prepared for accessing prenatal testing. However, there are still about 30% families where there is a new mutation, and so when they have a child with hemophilia, they need the most support and the most counseling. And the counseling, as Dr. Patke said, you need both genetic counseling, and we also need to do medical counseling to make the family aware about the disease, what precautions to take, and what treatment is available and where the treatment is available. I feel our Indian population is very intelligent, and if we give the information in a simple way, they can use this to improve their genetic literacy and to then decide what is best for their family and the future of their family. In order to increase this information, my colleagues and I have started GAP Health, Genomics and Public Health. The government is doing a very good job in training counselors. There's a curriculum about genetic blood disorders, which includes thalassemia, sickle cell, and hemophilia. And the counselors are trained to explain the inheritance and the options available to the families. In order to arm our future generations with this genetic literacy knowledge, there is now a move to include the genetics of blood diseases into the CBSE curriculum. And many of my colleagues and myself are actively involved in doing public awareness talks to explain to our population about genetic diseases, of which hemophilia is one, but there are many other genetic diseases, and many families are not aware about their family history, which is a very important information, as all doctors know, and which now gradually the general public is becoming aware. So knowledge about the disease inheritance, the disease process itself, and the treatment is definitely going to help our population. Thank you.
Thank you so much, ma'am. That was so simply and so nicely explained by you. And definitely, as right, yeah.
Just
Yes, ma'am,
Dr.
please.
Asawari, what she has already told, I just want that to add to it or sort of stress
Yes,
it, that when every pregnant woman goes to an obstetrician, it's very important that obstetrician takes family history in the form of pedigree chart, and then maybe hemophilia, Duchenne muscular dystrophy, and out of thousands of genetic disorders, appropriate families who are at high risk of genetic disorders need to be identified at that stage. So this type of activity and awareness among obstetricians is increasing. We are doing the training programs for obstetricians, and same way pediatrician who sees the patient with any genetic disorder. So at these 2 points, earliest interventions are necessary, and there probably neither hematologist nor geneticist will come into play. So basic care physician has to be aware about the genetic disorders and need for referring them to genetic center and offer genetic counseling. That is a very important step for prevention of genetic disorders, say hemophilia or hemoglobinopathies, and more than 5,000 genetic disorders.
definitely, ma'am. So rightly said. Obstetricians and general physicians, as well as pediatricians, would be the first people that patients would come across and get in contact with, and they would be the first line where detection an early detection for these diseases and similar sort of rare genetic diseases would occur. So awareness amongst the medical community as well as in patients both is very essential for early detection of such diseases. So my next question is to you only, ma'am, Dr. Shubhra. With your decades of experience, please talk about the evolution and modernization of treatment for hemophilia over the years. Also, do you think that there is a potent difference in the treatment and care management of hemophilia in India than in other countries? Over to you, ma'am.
When I started my career in genetics more than 3 decades ago. And that time, the only 2 genetic disorders which were really taken prominent shape were thalassemia and hemophilia. Most of the genetic centers started their establishment of the facilities from the genetic diagnosis of beta thalassemia. And that time, we, as a very young person, enthusiasts who had learned about genetics and gene structure, so the easiest thing, what we thought that with recombinant technology, the genetic defect in beta thalassemia and hemophilia can be corrected by just gene therapy, and there will be cure. So then we used to tell the patients it's a matter of few years, and probably the whole basic cure will be there. And till then, you just have to manage with blood products and maybe hemophilia factors. But that hope gradually dimmed down over a decade or two, and found that there were no success stories in gene therapy. In fact, as compared to beta thalassemia, gene therapy for hemophilia was considered easy, because even if body can produce only 2 to 5% of factor levels, then the outcome will be satisfactory. But last few years, I think last 5 years, I would say, that so many success stories of gene therapy have come up, including gene therapy for hemophilia. So now we see that cure is in sight. Cure is like it's proved that cure by gene therapy is possible. Only the thing is when it becomes available to all patients, and whether it becomes available to our patients, and what will be the cost. So that is the ultimate dream, that probably every boy with hemophilia will be able to play cricket, because for everybody in India, playing cricket is very important. So I hope that this soon will become possible. But short of gene therapy, the other treatments for hemophilia, which made patients live absolutely normal life world over by prophylactic infusions of factors, that is still not available to our patients, most of our patients, unless their parents are very they have resources. So this is something which for few patients government is making them these prophylactic therapy available. This is the thing which needs to be happening soon, because at present our patients come to our institute and then we give them treatment, but in the process there may be loss of say a few hours to few days, and that can cause harm to the joints as well as it may be life threatening. In this area of prophylactic therapies with factors, the developments in factors technology making production, so long acting factors are now available. Other many other strategies of developing of drugs which are not directly factors but some other methods, and these are long acting. These have become available. I'm very happy to see and treat our patients with some of these our patients with these long acting factors, as well as drugs for those with inhibitors, because even when the factors became available through government, treating patients with inhibitors was a nightmare, because these patients the factors are not they are not effective, and the other bypassing agents are very costly and extremely costly, and their management though we used to like I would really appreciate National Health Mission and these blood cell that Uttar Pradesh has been giving these bypassing agents to us for last many years, and at least life threatening bleeds of patients with hemophilia inhibitors could be managed. But now with these other long acting factors, even patients with inhibitors, there is no they are not really, we are not much bothered about them, and these other long acting agents and long acting factors, I hope that government makes them available to all patients, and this dream should come true in next 1 or 2 years, because Hemophilia Federation also says that there is now all appropriate and optimum treatment should be available to all patients worldwide, no resource poor, nothing. And especially we are really proud and seeing nowadays that India is really coming out of the stage of developing countries and financial resources. We realize that for patients with rare disorders, financial resources are not less. And at this point, I would also like to mention that last year, 2021, long-awaited rare disease policy has come into existence in India. At least now it is on paper, and policymakers are aware and convinced about the need. Of course, lot of many steps are there, many hurdles are there, but I think once it is in place, it's a short time that not only hemophilia, many rare disorders with hematological or other problems, they will get optimum treatment as the patients in developed countries. So I'm very hopeful.
Definitely, ma'am. And so are we. And so rightly expressed that with the coming of this integration of rare diseases into the health policy recently, as well as post-pandemic era, we have seen the manufacturing capacity of India booming to its, different peak. We really hope that such new therapies and new hormones and everything for the treatment of hemophilia would be produced in our country and in good quantities so as to cover the population affected better. My next question is to Dr. Tulika Seth, ma'am. Ma'am, could you please let us know, other than this, what all are the existing treatment methods available for the management of hemophilia entirely? And what is the effect of immune tolerance induction in patients with hemophilia? If there are any, challenges to this that patients or the clinicians face, and what are the protocols for this therapy in India? Over to you, ma'am.
So treatment has to be done very comprehensively because there is a lot of facets to it. First and foremost is awareness and injury prevention. There are many things that can be done to avoid injury, like avoiding intramuscular injections, monitoring for trauma. So these things are really important because prevention is always better than cure. I would like to just state that gene therapy trials have now started in India, and the first patient has been recruited. So that is something that obviously at the moment is on a trial mode, but we're all very excited about this. The clotting factor concentrates are available in all the states of India through the government, which is an excellent program. And the clotting factor concentrates are available for emergency use in all the states. And in some of the states, it is also being done as prophylaxis, which is to prevent these spontaneous bleeds. And patients who are on prophylaxis, from going from 20, 30 bleeds in a year, they may go down to just 1 or 2 bleeds in a year. So prophylaxis is obviously the gold standard of treatment. We have the standard half-life clotting factor concentrates, extended half-life clotting factor concentrates, and now we have some non-factor products which can be given subcutaneously, and they can also control bleeding. So we have many agents that are available to us. For patients who have developed inhibitors, inhibitors are antibodies which develop against the clotting factor concentrates. So this happens in some of the patients who have hemophilia. And when it happens, then these patients, the clotting factor concentrate cannot be used because of these antibodies which destroy it in the patients, and they again become at risk of bleeding. And such patients have to be treated either with bypassing agents, which we have 2 available bypassing agents in India, or they can be used with treated with the newer non-clotting factor products. So patients with inhibitors and without inhibitors require slightly different treatment. And it's important to know if they have inhibitors, in particular if we're planning any surgery. The inhibitors are more common in severe hemophilia A patients. There are 2 major time points where patients are at risk of developing inhibitors. One is during the initial stages before they've had 50 exposure doses of clotting factor. But as these patients receive more clotting factor products, the risk of inhibitors actually decreases because regular treatment is protective of developing inhibitors. The other time point that they often can develop inhibitors is when they receive very high doses of clotting factor around the time of injury or inflammation or surgery. So these are the 2 time points we have to be very much aware, and we need to monitor. If a patient develops an inhibitor, the only way we can eradicate the inhibitor at the moment is by doing a process called immune tolerance induction. It's sometimes called ITI. And this is about 70 to 80% effective in eradicating inhibitors. We most commonly do this in hemophilia A patients because it's a little bit easier and more likely to have success. There are 2 major protocols. One is a high-dose protocol, in which high doses of factor VIII are given every day along with bypassing agents. And the other is the low-dose immune tolerance regimen, in which we use smaller doses of factor VIII every other day. The way that this works is by continuously giving factor VIII and monitoring these patients, we are able to finally exhaust the antibodies. And these patients can then, once their antibodies have disappeared, we need to check that the inhibitors have gone. And we do that by several processes, not only looking at the inhibitors by Bethesda assay, but also doing the factor recovery in these patients. And then once these patients have the inhibitor completely eradicated, they can go on to prophylaxis with the clotting factor that they were on before. So this is a very satisfying process, and we have done this in India. The main limitations to this are that you need to make sure that the family is aware and they are cooperative, because this is a very regular process. The interruptions of immune tolerance induction are likely to make this process fail. And you also need to make sure that you have a continuous supply of clotting factor, because again, interruptions are not good. So it requires a lot of planning. It requires some serious discussion with the family to ensure that they understand what is happening. This is because initially there may be times where the inhibitor may actually increase before it finally comes down. It may take up to even 3 years for this to be successful. So if you select the right patients, and we've done it in young children with hemophilia A who had inhibitors, and so far we've actually been very fortunate and had 100% success rate. So if it is done early on and it is done properly, you can then make these patients non-inhibitor and they can go back to their standard treatment. So that they can continue and have good quality of life with the available treatments that we have in India.
So, ma'am, I was just curious about this thing. While you were telling that such treatment is a very, planned and programmed sort of treatment, which might even take a few years for its, complete cycle. So, after completing the cycle and after putting the patients onto prophylaxis regularly, are there any chances of having to repeat this entire treatment in future? Or is it a one-time therapy?
It's usually a one-time therapy, so it's very important that you stop the immune tolerance induction when you're absolutely certain that the inhibitors have disappeared. The patient that we did the first immune tolerance induction was about 6 years ago, and I recently saw that patient again, and he's completely fine. The problems often happen when sometimes when you have an inhibitor, you stop using factor and you think the inhibitor has disappeared, but then when you re-challenge them because you've not done ITI, the inhibitor comes back. Or if you're doing ITI and you've not done factor recovery, you may miss a persistent low dose inhibitor. And that low dose inhibitor, if it is missed, then that can cause a relapse. So this is a very successful treatment. It is done abroad very commonly. And the current World Hemophilia Federation guidelines suggest that all patients with inhibitors should at least have one attempt to having the immune tolerance induction done, because it is well known that patients without inhibitors have better quality of life, mostly because they have better access to the clotting factor concentrates, and the bypassing agents are more expensive and more difficult to access. And so once you have an inhibitor, the quality of life and the treatment suffers. So if you're able to make at least 70% of your patients non-inhibitors, that is what the WFH recommends. Obviously, during the COVID times with the lockdowns and other problems, it was difficult to do this. But now that hopefully we are getting back to normalcy, I am hopeful that more immune tolerance inductions can be done for patients to make them inhibitor negative.
Thank you so much, ma'am.
Can I ask a question? I can just because with the expertise of Dr. Tulika,